So dealing with artifacts in stress cardiac MRI and CT examination, it's a very big topic. Of course, we cannot cover everything in 20-25 minutes. Maybe I have to be more fast, but I will try to give some useful information and of course to show some clinical examples, and we all understand that stress CMR and stress CT constitute key exams for ischemia and perfusion assessment. Of course, during the clinical practice, we are facing artifacts that can mimic or obscure pathology. And what it is an artifact, actually, the definition is that it is something that it is visible in an image, but it is artificial and is often determinal to diagnosis. So, understanding the causes of the artifacts and the approach to their mitigation is essential in order to improve image quality and crucial for the accurate diagnosis. And these techniques are different, stress EMR and stress CT, so we can have different categories of artifacts that they are related with motion, contrast-related hardware reconstruction, etc. And here in this slide, we can see some common artifacts in stress cardiac MRI, motion artifacts, dark rim artifact, the magnetic field inhomogeneity artifacts, ECG gating errors, and bolus timing errors. Here we can see some common artifacts in stress cardiac CT, also related with motion and step artifacts, beam hardening and streak artifacts, blooming artifacts, and contrast timing errors. And let's see some clinical examples and how we can recognize some of them, starting with CMR. And in this case, of course, we're starting with cine images. We see this destroyed image. Actually, we must not forget to have our coils activate. That was a signal loss due to inactivated coils. So on the right here you can see the image performed in the right way with the coils. So some technical issues here that we must be aware of in order to improve and fix our image. Breathing motion artifacts are also quite often. Some patients cannot collaborate well and tolerate and it is important to recognize. For example, here we see some artifacts due to the not good breath hold in the beginning, in the middle of the acquisition, and here with the good breath hold. Here is a patient that we examined a few weeks ago, 82-year-old male, that he had some atypical chest pain we can see here the pleural effusion, and there was a question if there is any apical hypertrophy and signs of hypertrophic cardiomyopathy from echo. So he referred to us for further exploration. Surprisingly, we saw this artifact in our image. This is a SSFP sequence. We tried to fix this artifact. We were not aware if this patient had any previous procedure, interventional or surgery. We tried with this gradient echo sequence. You see that also different artifacts in this examination, susceptibility, motion, ECG also. He was this patient with arrhythmia. So one tip is that in these cases we can use also real-time CNS sequences with a decrease in SNR, but we can better visualize the pathology. Of course, we couldn't make this artifact disappear, and making a review in a previous CT examination, that was a small coil in the lower part of esophagus, but also you can appreciate that with the delayed enhancement we managed to assess the pathology, hypertrophic cardiomyopathy, and also to see the related fibrosis. Going with stress perfusion, it is always necessary to start with some test images. It is called a dummy scan, in order to avoid artifacts like these, folding artifacts that could affect the field of view, and so can hide the pathology. Usually, traditionally, we have been using a gradient echo stress perfusion sequences for the assessment of perfusion defects. Here is a patient with left main and LAD circumflex high-grade stenosis stress perfusion. We see the defects, but lately we are using this SSFP perfusion technique that has a highest SNR and more widely used now in 1.5 Tesla, but gradient echo sequences fast boiled are using mainly in 3 Tesla scanners. And here we can see this multi-slice first pass myocardial perfusion diagram, how the contrast goes from the right to the left heart, and by applying saturation pre-pulses we can improve the image quality. Also, in order to avoid artifacts, we are using techniques with motion correction. Here you can see the perfusion sequence without movement correction. Some difficulties maybe for the diagnosis, but with the MOCO correction technique we can significantly improve the image. Sometimes ECG does not work fine, and we can use pulse oximetry sensor that are MR compatible, of course, in order to get nice images, and also for stress perfusion we can proceed with this examination with good image quality. Of course, it is very important to recognize what it is abnormal and what it is artifact, and Gorka mentioned before in his presentation the dark cream artifact that we have to be aware of, and actually it is a partial volume effect, and the Gibbs artifact is not a true finding. Here we can see an example. On the contrary, here we see perfusion deficits in different segments of the myocardium, and we have to keep in mind that perfusion defect occurs when contrast arrives in the left ventricular myocardium. It is more than 2 pixels wide. It persists beyond myocardial peak enhancement, and for several RR intervals. We can see that it is subendocardial or transmural. It is present and at stress, but not at rest. So this is also something useful in order to differentiate. It conforms to the distribution territory of one or more coronary arteries. On the contrary, dark cream artifacts are most prominent when contrast arrives in the left ventricular blood pool. It persists only transiently before the peak myocardial contrast enhancement, and approximately the peak set wild is 1. And from the literature here, we can nicely see this example during the peak, this dark ring artifact and the true perfusion defect that persists in several heartbeats. So this is a tip just to when you are analyzing stress perfusion, and when you are using adenosine but not regadenoson, you can search for this splenic switch of sign, this dark appearance of spleen during the stress phase. but this is something that we are not seeing during the rest perfusion, and this is a sign that our stress our stress procedure was diagnostic and make us much more confident for the final result. And here is now another clinical case. It was quite challenging. This is a 58-year-old male with some atypical chest pain and risk factors that he was sent to us for a stress perfusion CMR. This is the stress phase, and actually we see, I don't see with the light, maybe it's not so clear, Thanos, but you can see this some dark line that passes also from this inferior wall, from the inferior wall of left ventricle. But beyond this, of course, you see that there is something more here. Also this in the middle part and in the apical part. So although we see this dark band artifact, we see also a true perfusion defect, and that was diagnosed from us as a positive stress perfusion CMR, and we see also this improvement during rest. This is also more an additional information that strengthened our diagnosis. So we sent this patient to the cath lab, and this is surprisingly the findings. Actually, we don't see any critical lesion. We could expect a critical lesion in the right coronary artery territory, but we see this significant ectasia and the slow flow in the right coronary artery, maybe less in the left coronary arteries, and this is this ectatic formation and slow flow. It is also an underlying pathology that suggests endothelial dysfunction, and this is also important information. We can assess it also with a stress perfusion CMR, and these patients, there is a suggestion to be treated with aspirin. In order to save some time, I will skip that. This is a dark band artifact. We can find some useful information also in the literature, and the ways of we can overcome this is to increase the bandwidth or change the imaging plane orientation. I said before that stress CMR, it is important to combine with late enhancement, and also here it is important to choose the right inversion time. Here you see different examples with different inversion times, and you can see how we can improve the image quality with the right inversion time, and how we can have a more decrease the image quality with the wrong inversion time. Also in patients with arrhythmia, when we are doing LGE, maybe we can try to scan them every other heartbeat in order to improve these arrhythmia artifacts. This is another case with magnetic field inhomogeneity artifact that we can improve by applying seaming and increasing the field of view. Of course, more and more we are scanning patients with stents or prosthetic valves or devices, and nowadays most of the devices are MR compatible, but of course they can produce artifacts. There are techniques in order to avoid these artifacts. For example, here it is easier when we have patients with pacemaker. We can do this SSFP sequence, but as well gradient echo CNS sequence in order to get this very good image quality, but also in patients with ICD, and some tips we can improve our diagnostic imaging quality. Here it is another example, very difficult for us, a patient with ICD. You can see all these artifacts that produced by the device. We tried to apply gradient echo sequence, and of course we can improve here the image quality. Here is the artifact from the device. Unfortunately, we didn't manage to get very nice images with late enhancement, and some tips are in order to reduce its image artifacts, to do the imaging during inspiration, to swap the phase encoding direction, to get some atypical axis of the heart in order to achieve better image quality, and employing wideband LGE imaging. Here is an example from the literature that shows the conventional inversion recovery LGE sequence and a modified wideband inversion recovery LGE sequence that it is very helpful in order to exclude this artifact from our region of interest, and we can nicely see the fibrosis. There are wideband perfusion stress sequences that are prototypes or in a research progress progress, but also we can see from this nice publication that they used a modified spoiled gradient echo sequence, how they managed to get very nice stress perfusion images, sequences. We can see nicely the defects, also the correspondence with the LGE and the coronarography. I'm I think 5 minutes, Thanos, I have for the CT. Very fastly, Kostas already covered quite a lot of the artifacts that we are facing with stress CT perfusion. There are different techniques, static, dynamic, dual energy, and different techniques. We can face different artifacts. The benefit of the dynamic stress CT perfusion is that we can get numbers and make quantifications, but with the cost of higher radiation. And in stress CT perfusion, always we combine the perfusion imagings with the anatomy, coronary artery anatomy. There are different protocols we can discuss after, also in the workshop in the afternoon, about the stress rest protocols or rest stress protocols. And in this exam, we can face artifacts during the coronarography, like this blurring artifact, that it was due to some irregularities in the heart rhythm, but with different phase reconstruction, you see that we can significantly improve the image. Or this is another case with a patient with a stent in the right coronary artery. We can see this artifact also due to some arrhythmia, but with a dedicated protocol and a dedicated reconstruction. In this phase, we can assess the stent. Still, we have some artifact here, but with another phase, we can overcome also this artifact and nicely assess the coronary artery. It is important, especially when we have a lot of calcification or stents, to have reconstruction, high resolution, and with more sharp kernels like this, in this case, or in this case that we see nicely the stent. Here is a calcified plaque. I see that we can, I think that we can appreciate this decrease in the blooming artifact that can produce calcium, and we can nicely assess the lumen. Okay, during the perfusion, with dual energy, it is the machine in shuttle mode with repetitive movements back and forth of the CT table. Before the reconstruction, there is a need to correct image artifacts, and we are using motion correction techniques. And also, it is very important, the patient preparation, in order to have a good breath hold and less artifacts. So just an example here, how we are using this technique, movement correction, in order to improve image quality and we can have this homogeneous enhancement of the myocardium. In this publication, they showed that this beam hardening artifact that usually we see in the posterolateral basal wall of left ventricle with dual energy techniques and increasing the energy levels, we can overcome this artifact. And I will finish with one case of a 66-year male with prior history of PCI in LAD and circumflex arteries and known RCA obstruction. He presented with atypical symptoms. Also, he had a mild hyperlipidemia. That was our one static dual energy CT perfusion that we performed together with Idris Hussain, a great friend and applicator specialist. We actually got in the same time coronarography and dual energy perfusion. And from coronarography, we assessed the coronary arteries, the known obstruction in RCA. Here is the stent in circumflex artery, but with better reconstruction with thinner slices and a sharper kernel, with better can assess the patency of the stent. Also here is the patent stent in LAD, but it was very difficult to assess anatomically the ostium of LAD due to the projection here of the stent in the circumflex artery. Hopefully, with the dual energy, we didn't find any pathologic Hounsfield units in the anterior wall. Also, we saw with the delayed enhancement this old infarction in this territory. This patient, after a couple of months, due to persistence of symptoms, he had a coronarography that confirmed the patency of LAD, circumflex artery, and the obstruction of right coronary artery. So this is a summarizing table with the most common artifacts in stress MRI and stress CT. There are different techniques that we can use in order to overcome them. We can discuss it maybe later in a discussion or during the workshop. And don't forget that artifacts are quite common in our daily clinical practice. We are learning to face them. We are learning to live with them. We have to know them in order to avoid misinterpretation. And finally, after all, radiology is the art of seeing the unseen and making the invisible visible. Thank you very much for your attention.